I mean, you can, if you, depending on the material, it's thicker. But they can do that if they want. Now, a recommendation's coming out. We'll see what that recommendation is. But I will say this, they can pretty much decide for themselves right now.
Nationwide, and can I also nationwide, not just for hotspots, and then maybe this is best for Dr. Burks, but we've heard some differing guidance here. The WHO, even the Surgeon General, have talked about various studies that show that masks, in addition to maybe not even being helpful to protecting people, may actually increase the rates of illness because people touch the masks and they touch themselves.
Sure.
Can you talk a little bit about just the evolution
of the
thinking on this?
Dr. Burks, and you might mention that other point also.
Yeah.
No, thank you. So I hope you got from the conference today that we're triangulating data that we know from the case numbers, the testing numbers, the supply chain numbers to create an integrated picture so that we can really support hospitals in their needs. And I think that level of granularity is really critical. Secondly, I just want to make the point that we really applaud the governors that are looking at a whole of state or a whole of metro approach. And what do I mean by that? The United States, going into this, had about 160,000 ventilators across the United States and another 60 to 70,000 anesthesia machines. That's about 5 times what most of the European countries have. But it's a matter of distribution to need, and I really applaud the governors that are bringing together their public hospitals with their more private hospitals and their visibility across their state. Because what we tried to talk about yesterday is every state, every county is different, and that's why we're looking at it at that level of granularity. And as we move through this epidemic, the needs need to be very tailored to those counties and frankly those hospitals. I mean, there's a reason why the president and Mr. Kushner have been very much involved in finding out what the public hospitals need. Why is that? Because the public hospitals sometimes have the weakest supply chain because they're often sometimes not as attractive to private sector distributors, or they may be too busy caring for the needs of patients to be really on top of their order forms and their supply chains. So really listening to the community that's at the front of this fight and getting feedback from those specific communities, no matter where they are, and listening to the frontline healthcare workers, because it's their reality that is important to all of us, whether you're the mayor or the governor or the federal government. And if they're saying they need something, we have to work together to supply that. And so that's what you're seeing with this triangulation. Every county will move through this differently, and that allows us to move around these vital issues that protect the frontline healthcare workers and protect the patients through the ventilators to make sure that the supply chain is aligned with the need as it happens. Now, you have to have very good data in order to be willing to work in that level of granularity. And that's what we've been working on to really develop that level of granularity to ensure that. So I just wanted to say one other thing about testing, just to give you the bottom line data of what we're seeing. We appreciate the groups who are reporting. Not everyone is reporting yet. And this is part of us trying to understand at a very granular level. We do have 2 states that do have 35% positives, and that's New York and New Jersey. So that confirms very clearly that that's a very clear and important hot zone. Louisiana, though, has 26% of their tests are positive. Michigan, Connecticut, Indiana, Georgia, Illinois, so that should tell you where the next hotspots are coming, are at 15% test positive, and then Colorado, DC, Rhode Island, and Massachusetts are at 13%. There's a significant number of states still under 10%, every one that I didn't discuss. California and Washington remain steady at an 8% rate. So what we're seeing finally is testing improving, more testing being done, still a high level of negatives in states without hotspots, allowing them to do more of this surveillance and containment. And then prioritizing this new rapid test kit to those areas that may not have the same amount of access to the Indian health services and to the public health institutions and the public health and state labs, so that they can use that and start forward leaning into surveillance. Now, we know that our people waiting for tests, and they're waiting for tests because when these areas became when they got onto the logarithmic curve, we prioritized people whose decisions, where the test decision would make it critical for their care. And so we prioritized hospitals, and we prioritized nurses and doctors and frontline workers. So that means if you went through a drive-through or you went through your doctor, you could have that delay. So the math. So what I tried to give you is how we're using data in a very granular way. And so there's experiential data when you look at communities that have oftentimes utilized masks in general for personal protection from when they particularly are themselves sick and have used their mask in public. And we've looked at the rate of this COVID-19 in those populations, and then we're looking at the scientific evidence to bring those two pieces together. Let me just say one thing though. The most important thing is the social distancing and washing your hands. And we don't want people to get an artificial sense of protection because they're behind a mask. Because if they're touching things, remember, your eyes are not in the mask. So if you're touching things and then touching your eyes, you're exposing yourself in the same way. So we don't want people to feel like, oh, I'm wearing a mask, I'm protected and I'm protecting others. You may be protecting others, but don't get a false sense of security that that mask is protecting you exclusively from getting infected, because there are other ways that you can get infected because the number of asymptomatic and mild cases that are out there. And so this worries us, and that's why the debate is continuing about the mask, because we don't want, when we're trying to send a signal that every single person in this country needs to stay 6 feet away from everybody, that needs to be washing their hands constantly and know where their hands are, to send a signal that we think a mask is equivalent to those pieces. So when the advisory comes out, it will be an additive piece if it comes out, rather than saying this is a substitute for. And we want to make sure everybody understands it is not a substitute for the presidential guidelines that have already gone out, and to be absolutely clear about that.
Quick question about the test, Dr. Burks.
Dr. Burks,
a quick.
there's a lot of evidence we're seeing that experts are saying that a high number of these tests could be producing false negatives. So,
Of the Roche and Abbott test?
that as many as 1 in 3 tests might be providing false negatives. I wonder maybe you could
That would
talk a little
almost
bit about
be
the science.
impossible with having 35% positives. If that was true, you would have
Sorry about
100%
the underlying
positive or
data.
66% positive. So what I can tell you is the number of positive tests is tracking very closely with the number of cases diagnosed. So I will look into that. I look at the Roche and Abbott numbers every night. They're trending exactly in the same way. And that's important when you're validating data, to really validate, does this same site, in other words, I'm looking between testing sites to see, are there consistencies? Is there an anomaly? To make sure for what you just very specifically asked. So I will go back and look at it more carefully. I haven't seen that kind of anomaly. This same platform is being used across the country, and that's a range from what I reported, 3% positivity up to 35% positivity. And that range reflects also what we're seeing with the hot spots and the number of cases. And frankly, I mean, we hate to talk about it, but it also tracks with the hospitalizations independent of diagnosis and the mortality that we're seeing. So all of those pieces validate
Concern
together.
that people might be getting a false sense of security, or that we might not be seeing all of the data here on the
Well, I'm telling you, I'm still missing 50% of the data from reporting. I have 660 tests reported in. We've done 1.3 million. So there is, and it could be those sites. So we do need to see all, the bill said you need to report. We're still not receiving 100% of the tests.
Dr. Burks, with regard to the test, the president's sample collection took 1 minute, results were reported back in 15 minutes. I realize you're the president of the United States, but when will everyone get to take a test that works that quickly and you get results that quickly?
So these are new tests, and we have prioritized the groups that we think have the least access to testing now. And who do we mean by that? We mean the Indian
presidential 15-minute test.